So, welcome to NUR 203. This is pediatric nursing. Pediatric nursing will encompass all sorts of things in nursing. It starts with serious, it talks about assessments. We go from infants where they cannot lift a head at birth to their adolescence, and now they're having sex and driving cars, getting ready for college, okay? That is our variety of patient population. It's a lot of stuff. So a lot of things to learn. Growth and development is a big thing, okay? So, what am I going to do today for you? Well, every class I'm going to do, first of all, I'll give you an announcement. What's going to go on today? What's expected? What are your assignments due for today? I think those things, are important. Week one, if you have read some of the information, it's good. I know most of you have taken the week off and just had those memories just cleared for a moment because getting through last quarter, now you got this one. So I understand that reset button. I do understand that. This week, all we have is a discussion question. Be careful with a discussion question. I ask about who you are, and then I talk about infant and nutrition. Okay, so make sure that you answer it. It is APA, so I want references. And if you know how, cite where that reference came from. For instance, if you use the book in parentheses, it's Perry, and you can even put et al, comma, 2023 in another parentheses. And that's in the body of the paragraph. Now, tell me about yourself. I don't need a reference, but about infant nutrition, I would, okay? As we go along, and when you see the discussion questions, I write notes in the text. So even if you got the 20 out of 20 perfect, please go back and look, okay? I will always give you insight. I will always give you feedback, and try to help you. So that's the first discussion question and what's due. Next week is our first quiz. Quizzes are at the beginning of the class on the last week's material. So this week is going to be on next week's material. It is 10 questions. Now, every week I give you PowerPoints. And when I'm done with the PowerPoint and teaching you, giving you all sorts of examples and things I've seen in my clinical life, I've been almost 50 years. I don't think of that and go, holy, 50 years I've been a nurse, and I've loved every single moment of it. I've done adults, I have done children, I've done everything but OR and labor and delivery. Although I have caught many an infant coming out in labor delivery when I was at a big county hospital and I would resusc the infant. So I have broad experience. You're going to see this is invaluable when I start talking about disease processes like diabetes. What's the difference between children and adults, right? I'm going to put it all into sense for you because med-surg 2 and peds, they coincide. So you're going to see me teaching something and you're going to help you more understand in your med-surg classes. So I know that, and I try to emphasize that as I go along. So first, I'm going to do a PowerPoint and teach you all about the rules of online nursing and what my expectations are. And before I start, my expectations are communication. If you can't do something, let me know before. If you're having an issue, let me know as soon as you can. Talk to me, I'll work with you. No talking, I can't help you. So please communicate. My cell phone number is on the about the instructor or Professor Betty Bogart, which is in your modules page. My cell phone number is there in case you lose it, but it's 305-951-8055. Use the cell phone when you need to know now, because that's your little time that you have to get something done and you want to do it now. You can't get to it or something's happening, you need a response. Send me a text, and that way I'll get it the quickest, okay? So that's what I'll do for you. So we'll do a PowerPoint on the rules, then we're gonna do a PowerPoint on this week, and then hopefully I'll have a time to do the Kahoots. Kahoots is an immediate quiz testing on the concepts I just taught you. So if you come to class, at least look at the information. then listen to my lecture. That's the second time you've seen it. And then I'll give you a Kahoots repetition. That's 3 times now. You've heard the same information, the same concept, and hopefully that's going to help you understand and learn. So let's go ahead. Let's keep going. Any questions at any time, stop me. Okay? I don't get upset. I don't get offended. And if I can answer you, I will. And if not, I will look up the answer or find out the answer, and get that information for you. So this was made initially by Dr. Brown, and Dr. Brown goes exactly by Fortis rules. It's the student handbook, the faculty handbook. It's all what there. There's no deviation from that. So if you're ever concerned, are we teaching the right way? You go back to your student handbook. That's what you have it there for. Online, just make sure that know that your class is an online program, which means you have to come on Zoom once a week and talk to me and me talk to you, and we do some learning. That's what we do. Then you have your Canvas shell where you're going to be doing your homework, admitting, putting it in and answering discussion questions, et cetera, et cetera. Now, what goes on, behind the scenes? Now, if something's going on, something that is bothering you, something happened. First thing that you need to do is contact me, okay? If I cannot be contacted for some reason, I want you to contact Dr. Brown. Now, they would say go to the lead professor. I am the pediatric lead professor. So I'm your first shot to go to. If you can't get me, please call Dr. Brown, email her, text her, canvas her, whatever you want, and please explain the information that's going on. I don't get upset by that, okay? I will not get upset. Dr. Brown and I work very closely together. And if you need help, that's all we want is you to get what you need. Okay. So again, first contact me, and please put it in a message, whether it's Canvas, whether it's an email, and let me know exactly what you need, and I'll get back to you, as soon as possible. So Dr. Brown, how do we get a hold of her? Well, we have my email's there for you. I've already given you my phone number. And the National Dean of Online Nursing is Dr. Brown. There's her phone number. She answers it unless she's in a meeting, okay? Or she'll answer it right away. I don't think the woman sleeps, okay? Maybe 3 hours a night if she's lucky. She's awake early morning, 4 in the morning till midnight. So she is there and available for you. She's great to have as a boss. Now, as you're communicating, always remember how you're communicating, how you express yourself. Those giving text messages in capital letters, they are considered rude. It's not professional. So always remember, we are becoming professionals. I'm a professional. I've got all my degrees. You are becoming professional registered nurses. So always expressing yourself in a professional manner is what we want. I don't mind humor. I don't mind having fun, but always in, a manner that's, not offensive to anybody. Okay. Remember, I start at 2:30 this class. Attendance starts at 2:30. We do attendance by 15-minute increments. So if you come at 2:31, 15 minutes will be taken off. Okay. At the end of class, I have a question to ask all of you. Now, I can teach and give you minimal break between PowerPoint and your Kahoots during regular classes, knowing that you're going to get out of class a little early because we went straight through. Do you all need a break in between, or do you want to go straight through and get out earlier in time? And I need for you to tell me what you want.
Straight through.
Straight through.
Straight
through.
Straight through.
Straight through.
Okay, that's fine. It doesn't bother me. Now, if during this time that anybody needs to have go to the bathroom, get something to drink, something happens, somebody knocks at the door, I mean, those things, some of those of you that are home, it's okay. Send me a little message, just in the chat, go to the bathroom, be right back. That's all I want to see. And that tells me where you were in times, et cetera, right? It's all I ask for. I don't care if you drink or you eat, but again, professional. Don't sit there and be eating a big turkey leg or something. You know what I mean. Just be courteous as we do those things. I've already told you about discussion questions. Now, I've had questions asked about these discussion questions. Do I mind if we do the discussion question, we answer the post first, which means you're going to tell me about yourself and infant nutrition. And then that's by Wednesday night, midnight, 11:59 Eastern time. Now, they request 2 peer responses by Sunday, 11:59 p.m. Eastern time. I've had a question if they mind if you do it all at one time. I don't mind as long as you have enough peers to respond to when you're doing your peer post. How does that sound? So you don't have to wait between Wednesday night and Sunday. This semester, this term, most of you have 3 courses. You have community, peds, and med-surg 2. It's a lot of work. So I think that's one way I can give you a little bit of time back to you so that you can get all of your stuff done. So again, academic integrity. Quizzes are done, on Zoom. You can cheat all you want, but you're going to cheat yourself. Remember, I can see any click off of Canvas when you're taking a quiz. There's ways to check to go back, and it's called view a log, and I could see if how many seconds, how many minutes in between going back and forth. So be careful because again, that's academic dishonesty, and it could end up in a academic integrity violation, and you don't want that. Furthermore, you want to do the best you can because in the end, you're going to be a registered nurse taking care of people, and you want to do it in the best manner that you can. There's been cheating going on. Please don't cheat. Try to do the best you can. I know you're tired. I know it's hard. I know you want to do your best, but cheating is not going to help you, okay? If you need help, come to me. I can do 15, 30-minute increments. I don't have to be with you 4 hours, 2 hours, 1 hour. Whatever time you can give me, I'm going to help you, and I'll help you get through this course. But again, you have to ask, communicate. Again, when we're doing projects, be careful of plagiarism. Those and that's going to be on week 8, and I'll go into that, and just a project we do. I'll go when we get to the scoring thing. Again, the code of ethics basically telling you you're going to be a registered nurse, professional, and you have to maintain, that ethical values. All right, just be professional at all times, etc. Now, there are websites on the internet. Some of the names, and they're not all here. Sudoku, Course Hero, Stuvia, et cetera. People go in there and get projects and download them or see tests, exams, et cetera, et cetera. If we see you on them and they do monitor these sites, you will get an academic integrity violation up to dismissal from the program. Be careful, be careful, be careful. Now, every week, like this discussion question, is due on Sunday at 11:59 p.m. If you, for some reason, you can't get it in, let's say you were supposed to do it Sunday, but you ended up with your daughter in the hospital. Well, let me know before it's due. Give me that documentation that she was in the hospital or the ER, urgent care, whatever, and I will give you one more week. Now, after that second week, then it will be considered a 0. If you do not tell me you're going to be late, you will have a minus 10% deduction for the second week. Okay? Attendance. I've mentioned it several times, but I'm going to tell you a little bit more. Number one, it's being here on time. It is that 15 minutes increments. If you leave early or come in late, that time will be deducted. And be careful, those 15 minutes add up pretty quick. You will get letters from the dean and her secretary telling you when you're 5%, 10% missed attendance. Be careful, because at 20%, if there's no documentation why you are missing class, you will have one full letter grade deduction, and it has been done. Another thing with attendance, it's not just showing up and spending your time here with me, it's also going into your Canvas shells. So I've had questions wanting to do all the NCLEX questions up front and submitting them. Do not do that, because I don't care if you do them early, because I know that many of you, again, want to get your work done. I don't suggest it. I think that doing NCLEX questions before exams is your best bet. It gets you studied for that exam. But if you're still going to insist, only submit one at a time, because Canvas has to have 2 points of contact every single week, which is your discussion post, and it's the answer to that discussion post. So that's 2 times this week. Plus, you've done the quiz, literary quiz, and all that stuff already. And remember, that has to be done before you can open up the other modules. So those first things, literary and those quiz has to be done, syllabus quiz, etc. So make sure we get 2 points of contact. I mean, if you're doing a case study, you're doing a project, it's good. But there are some weeks that are weak. Be careful. Hand in the NCLEX questions on the week that they're due, okay? Again, attendance, I've already talked about it. I don't need to say any more. I've already told you that we're going to call you. We're going to tell you about those 20%. We send messages. And how do we be successful? Well, every week, if you've noticed this week, I sent an announcement. And that announcement shows you what are the chapters that are due, and it shows you any information that I want you to have. I sent you a vital sign sheet and something called an Erickson sheet. Those are things that are handouts that'll be very, very helpful. Why do I send you a vital sign sheet? Well, is there a difference between vital signs of a newborn baby and an adult? Yes. Heart rate, 140 to 160, respiratory rate, 40 to 60 on a neonate, first 28 days of life. And of course, you know what adults are, 100, 60 to 100, and respiratory rate, 12 to 20, right? Big, big difference. But as we get older, those numbers are changing. When you're a toddler, when you're a preschooler, you have to know what those vital signs are in order to treat. Are their blood pressure's too high, too low? Is their heart rate too high, too low? Can you give that med? Do you need to give fluids? This is all based on vital signs. So that's why you have those things. So every week you're going to be getting what is due. And I do that every week, the chapters and what is due. And when I send you your recordings, I repost your PowerPoint. I repost the Kahoots for the first time for you. Okay. And any things that I've handed out for you. All right. If you follow that, you'll be good. And again, the syllabus is your guide. I take it from the syllabus. Again, always log into your class, as I told you. If you can't get something done, please let me know. First day one, as I said, walk in, know your online courses. I've already sent you your syllabus, so now you have it. I'm always available, basically, except early mornings. Honestly, I don't like mornings. So if you want to get a hold of me, something urgent, please, after 11 would be better for me. Once I'm awake and have some coffee, it would behoove you. In the mornings, I'm a little slow. I have something called rheumatoid arthritis. And in the mornings, you tend to be foggy. And yes, you are. It's just part of the process. So I'd rather talk to you when I'm more alert. Come to class. If you've read your material with questions, I don't understand that. And what does that mean? And again, if you're not understanding it, even in class and all the explanation, make an appointment, come see me. We can do tutoring sessions. Anybody who's a reentry has to see me every week. Okay. Anybody who's a repeat should see me every week. in order to get you through this, or at minimum before exams to help you get through this, okay? I don't do weekly sessions as per se as in study sessions. I'm here before class, after class, and if you need me, whatever time during the week, I'm here to help you with it. I've met some students on weekends where that's the only time because of work schedule, family schedule, etc. They could meet. Okay, let me know what's available for you. I'll work with you. So I said, tutoring helps and you'll do better. Now, part of your syllabus is how this course is graded. So we have the KGA, key graded assignments. It's exams, quizzes, and your HESI. You have 3 exams, week 4, 7, 10. Quizzes, we start them next week. Each quiz is 1% of your grade. We have our NCLEX questions. CJ Sims are worth a lot. They're both worth, 1% or more for each assignment. So it can make a difference in your grade if you're that borderline in the end. There's one dosage calc question form that we have. It's there for you to download in your modules. We have 2 HESI practice things before the HESI. They're both worth 1%. And then you can see this pediatric assessment. It's 6%. Think about as we go along in this course, is there a diagnosis on a child that you want to know more about? Did your child, did your friend's child, or did you see someone with this diagnosis and want to know more about it? So pick a diagnosis. Now, when you go to your modules week 8, you're going to see a whole list of diagnoses. They're only a guide. It's not for you to choose one of those. It's for those who are like, I have no clue. And then you choose one, okay? You can choose whatever you think pediatric diagnosis would be, okay? And as we do that, we're going to go along. I'm going to tell you when to start doing it so you don't end up on week 7, 8 with community things due, my things due, and a horrible med surge test. So I'm going to be telling you when to start your paper, when to start this and that to try to get you beforehand, okay? And those who do it are grateful that I had them do it that way. We have homework grades are turned off for the first 5 weeks. That means that 20% of all of those extra, we call them homework. Some of you call it the busy work that has to be done, right? Those are 20% of your grade, and those are off. Now, on week 6, I turn them on, and it shows you how those homework grades, if they're not done, how it will affect your grade. I just had last quarter one student fail for not doing all her homework. And this student had over an 80 average in my class. So it can happen. So be very, very careful. We turn them off again on week 8. So we're just seeing our KGA, knowing that you need a 78 on your key graded assignments, quizzes, exams, and your HESI. Once you get that 78, all the remediation from everybody's in, then I turn on the grades and that will be your final grade. And then I'll let you know. When you come in for an exam, I don't tell you to come in on your phones for your quiz. On your quiz, I'm going to do a quick look over you and I'm going to have you do your quiz. On exams, you must come in on a separate device, okay? Because once you open your exam on your computer, Zoom goes away. So I need 2 devices. One of the things, make sure they are fully charged. I've had many students forgetting their charge cables, or they don't have a charge. You have to run and get it and plug it in. 1 second. Mm. All of a sudden, I felt very nauseous. Excuse me. All right, KGAs and your quizzes. There's only 1 attempt. I'm going to be right back. I apologize. I just got violently ill. Excuse me. Okay, here we go. Quizzes. I apologize. Quizzes are given in class. If you miss the quiz, you may not make it up. Now, what happens if the end of the course you are point something away from passing and you missed a quiz and you have documentation why you missed the quiz? Whether you're with yourself, this happened, that happened, and you can show documentation, Dr. Brown will let you retake it, but only at the end of the course. We do not re-give quizzes at all. I start quizzes from when you come in, and I have them open for the first 30 minutes for you to take them, and then we start class. After that, they're not going to be open, and you can't. It's 10 questions, 15 minutes, and you can't go backwards. Just like your NCLEX, it'll be the same thing. Exams, as I said, they are week 4, 7, and 10. On week 4, you're going to be coming to class, and you're going to be coming in again on that your cell phone or iPad, whichever you have. I've seen them do both, students do both, and your computer. It is through ExamSoft. Now, there will be a practice ExamSoft in case you want to do a practice. I'll be opening that as soon as I get ExamSoft. Usually it's next week when it gets open, so it'll be there if you feel you want to go and do that. Know that exams, you come in on your phones and we take it through your computer, and there will be class after the exams, and I'll let you know that on the day of exams, but to always be prepared to stay for the class. Exams is only one attempt. You cannot take it again. All right. Now, what happens if there's a lightning storm, hailstorm, your computer blacks out, it stops working, something, all right? Technical problems, quizzes, exams, notify me immediately. Immediately. Because as I said, I can see timestamps on quizzes, I can see timestamps on exams. And you notifying me immediately says, yes, they did have a problem. And then I can get them restarted from where you started. Another thing, sometimes in the end, exams don't upload. Students go, oh my God, I'm going to have to take it again. The exam is lost. It is never lost, okay? So don't worry about that. We can always retrieve your exam. Sometimes after the exam, it's usually one student of 3 classes every exam, they can't download it or it doesn't upload. So I will just tell you to restart your computer, go back, and it uploads fine, and that's what we do, or we call ExamSoft. If you have accommodations for extra time or quiet space or any of those sort of things, I have to know before an exam is due. See, notification less than 10 days before an exam, we don't know if we can grant all of it. We've got to increase your times, and then, how are you going to give those exams? Are you going to come in class time? Do we have to do another time? There's a lot of particulars with it. Anybody with accommodations, tell me immediately. And remember, there's a quiz on Monday. I will increase your time. I need that paper from Fortis that says, you do have extra time, et cetera, et cetera. If you want to take an exam on campus, and there's a couple students in a campus here that always like to take it on campus, I have no problem with that. I have to be notified by you 3 days before. Also, the faculty that's going to be proctoring you need to email me. I don't email them. Once I get that, I send them the access code and you can take it on campus, okay? As I said, Zooms are proctored. Be careful. No blurring of the background, no hats on the head, nothing in the ears. In case, you can be listening to things during the whole thing. If there's some reason why you have a hat on your head, if it's a religious or it's something, your doctor has an order for, those things, just let me know. I can work with you. I respect all of that. Missed exams. Let's say you got sick, violently ill, you had a massive migraine, and you were like me, vomiting. And all of a sudden, you can't take your exam. You don't feel good. Notify me before the exam. Let me know. I don't want anybody to take an exam who's under due distress because of something that's happened or because they're ill just to get it done. You're not going to do as best as you could. I would rather reschedule it. If you tell me before it's due, I will not take off minus 10%. If you don't tell me, don't show up, and then schedule the exam, it will be 10% off. So you'll start with a 90. Okay, be very, very careful with that. I work with you. So let me know what's going on. I can work with it. But again, before it's the exam, let me know. It's basically just taking exams, quizzes. Excuse me. Quizzes are in Canvas. Next week, I'm going to have you go to week and modules, week 2, and that's your quiz. You click on it, and you're going to take it. You'll see your scores right away, and but you can go forward and not backwards. Okay. Again, any problems? Let me know right away. I can take care of it. I can look at it, as I said. HESI. I've got a great HESI review. If anybody wants that earlier, let me know. I can always send out some other information I have. I don't mind giving you any extra. I just don't want to give you so much that you're overwhelmed. And that's what happens many times. You have so much. What do you study? And it becomes, I'm confused. No, I have Kahoots, two Kahoots I give you, which show all the concepts, 100 question Kahoots. I also do what I call a HESI Q&A. It looks at growth and development, different diagnoses, and look at what do I want to do with that diagnosis, okay? Most of all, my HESI overall mean scores are over 900 if you do what I tell you to do all the way along, okay? Remember, there's remediation afterwards, so that they need to be done. They have to be in by Monday night or Tuesday morning of week 12. If you don't do it, and I'll be sending you reminders, of course, you'll get a 0. Again, exams, whatever you show, either school ID or your driver's license, and we do each person at a time. I'm going to do a review of your area, et cetera, et cetera. Those at Indianapolis, usually you have a proctor in there with you, and they can do all of those things with you. I just need licenses for the recording. Again, anything, any problems, let me know. Homeworks, I'm going to tell you when they're due. Again, they're due by 11:59 p.m. Eastern Time, and I will be putting in your announcements. I'll be reminding you, etc. So just get them in on time. And if you can't, let me know. Or if you have to take that second week, it will be a 10% deduction. The NCLEX questions are basically similar to what you're going to see on your NCLEX, your licensing exam, right? So doing those NCLEX questions, looking up answers, not just guessing, is the best way to do them, because it makes you look and think about those type of concepts, okay? And they are right before every exam. That's why they're set up like that. As I said, NCLEX questions are submitted every time that you do them. Now, I don't want to see that little green little square box when you send me up what you're giving me. There's a long page. It could be 12, 15 pages, 6 pages, and it will show me the areas of what you have done in the NCLEX questions. And that's why I need that. Now, if you see the first week NCLEX questions, you see a 0 and you did them, go and look at what I put in as your comment. I will not take the 10% off because you put it in on time, but they weren't probably submitted the proper format or you just did pediatrics, not growth and development, which is the first set of NCLEX questions. Okay, be careful with that. It is growth and development, not pediatrics. And it's a different section in your Saunders NCLEX. There's one for the children, the pediatrics, and there's one for growth and development. Infant through adolescence, you check and you get your 50 questions. You can do your NCLEX until you get the score you want. Once you submit it, that is the score you receive. You can't redo it, which is what I just said. As the assignment and practice exams are done through the course modules, they're done right before the HESI. They're comprehensive. They're 80 some odd questions each, and they really go over so much things. Again, it's going to show you where your weaknesses are before you go into your HESI. So these are good things. Now, these usually go from your grade book, your module, go right into the grade book. I shouldn't have to put a grade in on these. If you see a 0 or no grade on the HESI-RN practice or assignment exam, which is week 8 and 10, let me know. CJ Sims. Again, I don't open these until the week that they're due. And the reason is you're covering information on what the course is covering then. Dr. Brown does not want them open early. She wants these done exactly on the week they're supposed to. Make sure when you submit it, it's done in the proper format. Now you're going to see on the modules what it shows you to do. It used to say the name of you, but now it's your initials in the right upper corner. They switched that the last CJ Sims of last quarter for everybody, but it is, I need to show that it was you. Like I need BB in the top corner. It says it's mine. I need the patient, the date it was done, and the score so I can submit it. Again, that paper assignment that I'm giving you, I'm going to go over it a lot more. That's the pediatric assessment. Again, it's APA. We're going to do a 250-word paper to start with. Very brief. Just tell me what a diagnosis is. Then your second part is going to be an assessment that you do. The form is on week 8 in your modules. And then the third thing is teach me something. Now, let me give you an example. Let's say I'm going to do it on asthma, very common childhood disease, right? First of all, the paper, I'm going to describe what it is. Second of all, I'm going to do an assessment. And the assessment's going to reflect a child who's having an asthma attack. So there's going to be wheezing and expiratory wheezing, and there's going to be nasal flaring and intercostal retractions, et cetera, okay? And then the teaching might be how to give an aerosol or a meter dose inhaler, right? Or how to prevent getting asthma attacks. So that's 3 things. And as you do these things, you want to submit to me early. I'll grade them early for you so you can get the best grade you can. It is 6%. As you're looking up information, I want a minimum of 2 references on this. 1 reference doesn't work it. We need at least 2, 3 is even better. Make sure that it's current information. You know, the medical world has changed so much that newer information is going to be more accurate. Now, one of the ways that we look at, teaching is reflecting on how you as a nurse are going to be respond in the hospital or whatever situation you are as a nurse. And you can read it. It says, are you prepared? What remediation could the online instructor review with you to help? I mean, these are things I want you to think about. I want you to reach for help. And then I always want you to be as professional as you can and being accountable to what you've done or have not done. Now, this is the last slide, and it reflects a student. And it was actually in another professor's class. And she sent it to me, and I just thought it was such a thing, valuable information. She says that got an 1145 on the HESI. That's a 99.99. And she said part of it was doing the CJ Sims. And not only doing them, looking at the medicines, looking them up, looking at reflecting the NCLEX questions, understanding them. And that's how she did it. And of course, there's always the other information you have, but that was the start of it, that she did her due diligence as she did her assignments. So, any questions? Not yet? All right, let's go ahead and let's do our PowerPoint for today. So we have a lot of chapters. It's 26 through 30, 26, 27, 28, 29, 30, 5 chapters. And there's a lot of information in it. But you're going to see as I get to the cahoots how I bring it down to just the concepts in it. So pediatrics, it's all about children, right? The government is doing a lot of things on, populations um, that need extra help. One of the things is children. And we call these things healthy people. You're going to see healthy people. When I first started, it was 2010. And that was one of my first papers on healthy people. And the government focuses on certain things that they want to provide, whether it's dental care, whether it's uh, something about nutrition, outside, getaway, school lunches. All of these things are focused on these healthy people things. Any of you who want to go further into nursing, BSN, MSN, this is the place where you find a lot of your papers. And they're adults, children, all populations, disparities are here. You can pick out places and use it. I've done many papers off of these things. Healthcare for children. Biggest things that we're looking at is obesity and type 2 diabetes. Children are not out running around like they used to. They're inside playing video games. Moms and dads are working because you have to today. Lunches are those quick through drive-ins, which are high in fat and carbohydrates. And it is just what it is. So obesity is something that is epidemic proportions now. Type 2 diabetes because of diabetes, etc. Type 2 diabetes in children is usually adolescents. Younger children are type 1. Okay. Children get hurt. They tend to be, violent against each other and fighting or whatever. Vaping is a big thing with them. And you don't think about it, but children do have a lot of mental health problems. I've seen some children. I worked, my last position was at a children's hospital in the emergency room for the last 10 years. And I used to see children come in with really bad mental conditions and that were out of control of their meds. And they were doing, hitting their heads on the walls and hurting themselves and others and taking excrement and spreading it on the walls in the rooms. And they didn't know what to do with themselves. And it's really a sad thing. So it is there. Now, infant mortality. It's the number of deaths per 1,000 live births. The WHO, the World Health Organization, looks at stuff like this. And they look at the world as a whole. And when they say United States, we are not number one in healthcare of infants. We are way behind many other countries, okay? Know that the word neonatal means the first 28 days of life. After that, up to 1 year, they become an infant. Okay. I'm going to be saying it again next week, but I'm just letting you know. What is the biggest determinant of infants dying? It's their birth weight. Low birth weight, very low birth weight. These are small children, and there's so many things that can go on, their lungs, their brains, etc. Childhood mortality, death rates for children greater than 1 years old are less than for infants. What do you think? Well, infants, they're going to get sick. Whatever they were born with is going to, take over them, or they're born with all of these things going on and they die. No, they get all their immunizations and they build up their immunities and they make it to toddlers. Okay. Death rates for children greater than 1. What are they doing? What are toddlers doing? Toddlers are the dive bomb kids. They have no filter, no fear, and they hurt themselves. Everything in the mouth, detergents, poison, it doesn't matter. So death rate on those toddlers is up because they're more mobile. They can get into more stuff. It looks like the school age children, 5 to 14, 6 to 12 is the number, but it's right around that school age lowest death rate. You know, school age children want to please. So they don't want to do things that are bad, all right? And then adolescents. Now, one of the biggest injuries in children is motor vehicle injuries. Now, infants is the car seats, how you place them in there, right? Adolescents is now they're driving. So now you have adolescents, with motor vehicle accidents, doing all sorts of crazy things with cars, etc. And adolescents, and we're going to learn this more later and next week, no, 2 more weeks. Adolescents are all about their body image, and they feel that their body image isn't what they want, and they don't know who am I, what am I going to be. They're so confused, and I have too many pimples, I have too curly hair, I'm too fat, too skinny, whatever. And because of that, it's suicide is a big thing in adolescence. So we've talked about specific groups, childhood morbidity, with living in poverty. We can understand that. I've already mentioned low birth weights, chronic illness. If you're always sick with something, sometimes it catches up and it can, take the child for that. Why is there children in daycare centers for deaf? Well, what do children do in daycare all day long? Mostly they play, right? And they play with toys and they swap spit all day long, don't they? So now they're putting germ to germ to germ to germ to germ, and those germs could be bad germs. And of course, that could cause an increase in morbidity, mortality in daycare. Pediatric nursing. One of the reasons why many nurses don't go into it is because you don't just take care of children. You take care of the entire family, including that very, very demanding mother and father, right? They can be difficult, but they can be your best friends too. And they could be your biggest eyes and ears when they're in that room with that child and you have to be in another patient's child's room, right? So what is all about pediatric nursing? It is family centered care. The family is the center. It's what they know and they understand. They don't understand anybody else's culture. They don't understand anybody's other way of routine of a household, just daily routine. They just don't. They don't know the foods, they know nothing. So all they know is their family. Okay. One of the things about children, and we've started to recognize, is one of the things kids are afraid about is all about they're going to get a pinch, a needle, a stick, right? Oh my God. And they run in the opposite directions. Now, my PhD dissertation is school age children's attitude and behavior towards injections. And why did I pick that? Well, working in the emergency room, I saw many children see that they were getting an injection. They open the door, run down the hall, and out into the parking lot because they were afraid. And then I'd see another kid sit down and say, okay, go ahead. And no big deal. So again, it's understanding the child, minimize physical distress, physiological distress, and make it as an easy as possible situation, using whatever numbing creams, distractions, whatever. So nursing, try to do it without pain, right? Pediatric nursing, you're going to be a counselor. You're going to be a marriage counselor. You're going to be a family counselor. You're going to be everything. You're going to be the teacher. You're going to teach family. You're going to teach the child. And of course, trying to teach to prevent injuries. So pediatric nurses, as I said, we're going to counsel and we're going to coordinate and make sure that they know what they need to do. So adolescents, leading cause of death among African American boys, 15 to 19. And you could say, I think two things here, right? Firearms. Why? Because now they're curious. Now they think they're big and old enough that they can handle it because now that they're a teenager, they're an adolescent, right? That's when accidents occur. And then, of course, suicide. It's that body image. They don't like themselves. All right, let's go into some other stuff. Family, social, cultural, religious. I've mentioned a child only knows his own family, his own culture, his own religion, his own food, his own everything. So, do you know that child stuff? No, you only know you and what you've been exposed to. So, what is a family? Family is whatever they say it is. A family could be adopted families and a child. It could be a mother and two and the child. It could be two mothers, two fathers. Could be a mother, a grandmother, a grandfather. It could be anything. Just remember, a family is whatever they say it is, okay? There's all different types. You make your family, you stay together, you have your traditional. And then you have husbands and wives with other husbands and wives getting together with children, and now that's your nuclear, your blended family. Okay, there's all sorts. Family strengths, families can be your biggest help. And I know that families only want their whoever child's in the hospital to get better. One of the things is to know um, who is the say so in the family? Is it mother or father or is it grandmother? Could be anybody, right? And know how do they learn, all right? Always include when we're talking about teaching and making a care plan, taking care of the child, and that includes after hospitals on discharge. How are you going to take care of that child? Include them. Know that parenting, there's all different styles. You've got that very strict one and you've got lenient ones. Remember, again, there needs to be a certain discipline, even with you in a hospital, that they have to attend to, okay? We know that parenting an adopted child, knowing where did they come from. Again, it's for instance, and why would that be important? I'll give you a great example. What if you had a child that was from the area of the Mediterranean Sea, and all of a sudden they got sick and they were anemic? Well, that has the possibilities of thalassemia because of Mediterranean. Okay. So knowing where they came from could help you focus in on what could be that possible thing. Okay. Also, you can have those cross racial type things, an African, an American, a German, and a this, and it doesn't matter who, they're all have different things and conditions that could happen. And just being aware of them can help us take care of these children. We know there's all sorts of things that happen with parents and divorce, etc., single parenting. I've told you about this. These all sorts of parenting things that we might see. Nurses, we have to know how to allow your patient and your family to be able to do whatever cultural, religious things that they need to do if they're in a hospital, okay? And how do we do that? I ask. Do you need time do you need special food? Do you need special prayer time? Is there anything I need to know? Oh, you can't have men taking care of your daughter. Okay, what is those circumstances? Let me know. Again, the only way you can know is to ask questions. And I want you to know a parent will be very, very pleased when you ask. It's when you don't ask and you don't do it right, that's when you're going to have problems. So I've always learned this. I don't know. I said, can you teach me? What do you need? How can I make this better for you? That's all you have to do. So a frequent health problem of migrant children and adolescents in the United States, and it's basically TB. They're not tested like we are here. We test for TB all the time, don't we? All right, genetics. Growth and development. Well, I started out telling you about the infant that we're going to take care of. Baby's born, say 7 pounds. They can't lift their head. They don't know how to breathe at first, do they? We spanked their butt and we made them to breathe. We teach them from the moment they come out of mommy, right? They can't lift their head, nothing. By 1 year old, they are walking and talking. 12 months later, and they've tripled their birth weight. Is that bloody amazing? I think it's the most incredible thing to watch a newborn not do anything. You have to teach them how to suck on breast or bottle and teach them how to burp, teach them everything. So it's growth, development, maturation, differentiation. The only thing to know, it's always interrelated, simultaneous, and ongoing. And I'm going to show you what those growth development steps, the ones that you need to know. I'll go into that further, all right? So what do those words mean? So basically in growth development, before you can walk, you have to creep. Before you can roll over, you lift your head. So your head lifts over. It actually helps you roll over. So you do something before you get there. Now, it doesn't mean that a child is up on their knees, doesn't stand up and start walking right away. Most children don't. They stand up and now they're creeping and holding on to something standing, right? It doesn't mean they can't, skip a step as long as they're going forward in development. Now, developmental tasks and milestones, we watch them because we want to see, is the child cognitively where they need to be, or do we need to institute early intervention? I mean, you usually think of the toddlers are not talking, you order speech therapy, right? Everybody's heard about that. But what about the child who's 7 months old and can't lift their head up yet? That's going to need more intervention, right? And what is the beauty of children? They are resilient. You teach them, and they're going to do far more than you ever expected. Their metabolism's different. That's why the vital signs I gave them to you, right? Heart rate 140 in the newborn to 160. And then at 1 year old, they're 100, 120. Gee, big difference there. At birth, babies cannot regulate their own temperature. They come out of this wet, warm environment. We need to dry them off immediately and put them in a nice, warm area so that they keep warm, right? We know that they sleep, they rest. And one of the things you're going to hear me over and over again, nutrition, nutrition, nutrition. It's the single most important influence on growth and cognition. If you don't put gas in your car, does it run? You don't put food, nutrition into a child. Is their brain going to work? Are they going to be able to move right? So just think of it that way. Nutrition, nutrition, nutrition. And know that children are all different. You have the easy kid, the difficult child. Again, it's how you as a nurse will approach them. Now, one of the things that students don't like is talking about theorists. And there's 4 different ones that you're going to have to know about. Freud is one of them. And why do we want to know about these things? Well, these are theorists that discuss children and the way they respond to their environment, the way they think and the way they react. Okay? Now, Freud, anything sexual. And look at all the things. Oral is birth to a year. Why is it oral? Well, what does an infant do at birth? How do they soothe themselves? Anything in the mouth. How do they explore the world? In their mouth. Oral is that infant. Now, why is age 1 to 3 anal? Potty training. And bowel training comes before potty training. All right, et cetera, et cetera. So Freud, we're going to go into more of these as we go through these age children. Now, Erickson is about the environment around them. Okay. How do we react as an infant? Well, trust versus mistrust is the baby. They trust when they cry or make noise, somebody comes, picks them up, and attends to their needs. That's trust. They called, they called that person psychosocial. Is I know how to get somebody here and get what I need. Well, what is mistrust? Well, that's when the baby's never picked up. That might be a family of drug abuse or alcohol or just physical something abuse or homelessness or anything, right? Trust is when their needs are met and they're happy, healthy babies. Mistrust, this is going to be that child that's going to be harder to work with, and they have mistrust. And we're going to go over all of these as we go further. I don't want to overwhelm you with these yet. Now, Piaget is thinking, how do I think? Well, I took my finger, it hit my mouth, and I put my thumb in it, and oh, I started sucking, and I liked it. They didn't know how to do that before. That's their mind saying, oh, I like that. Now I can do it again. That's sensory motor. All right. So again, it's learning number one, taking a rattle and then putting it in the hand and voluntarily eventually, initially it's a reflex grasp that grabs it, but eventually they don't want that rattle and they voluntarily grab it. And then many times it will go in their mouth and they'll gnaw on it because they like it. So again, they've grasped a rattle. That's one concept. Then they shook it, it made a noise. Oh, I like that. Let's do that again. Oh, and then I put it in the mouth because that's the way I soothe myself. So language development. How do we start? What's the first thing we do? We coo and we cry, right? Babies, that's what we hear about. So again, this is the way that they express themselves to us. And we know, are they happy or not, just by cooing and crying. Now, the third, fourth, this is your fourth one. Your fourth theorist is called Kohlberg. When you think of Kohlberg, think of morals. Think about doing right. Okay? There's a consequence for doing it right and a consequence for doing it wrong. So it's reward and punishment for the younger kids. That's Kohlberg, all about right and wrong. If you can remember that Kohlberg, you're going to remember anything that comes up with that. Now, play. Oh my goodness, we're going to be playing, kids. That's all they do 24 hours a day, right? You put them down on the floor in the morning, they go in the toy box and pull out something and go, oh, I got my truck back. Isn't that neat? And there's all sorts of play, and I'm going to go into these. Socioaffective is playing with, toys and moving them around. Sense pleasure. That's when you put them in the sand or you put them in mud and let them smush it, or mashed potatoes on the high chair, or their food, smushing it, putting it everywhere. You're like, oh, they're making a mess. They're actually learning textures. That's the sense with it. And then et cetera, et cetera. And we'll go on and we'll teach you those. What does play do? Well, play makes them use their hands and their eyes and their body. They have to get to the toy to play with it. They have to take their hands, they have to use it. They have to have their eyes, they have to think about it, and then they have to use it. Sensory motor, sense, touch, feel. Children, infants, oral in the mouth and moving it all over the place. That's development. Okay. That's the basis of all growth and development there. Intellectual development, well, if I shook that and made a noise, I'm going to do it again. And then I'm going to build upon that. Maybe I bang it on something and it makes more noise. All of these things are development of a child and of their understanding, awareness, their creativity. I mean, putting a kid, letting them put purple paint all over, I mean, you may not want to do that, right? But I mean, it does give them, seeing it, something going on there. Now, what are the types of play? These are important. You will see these again. So, onlooker, I'm just watching you. I'm doing nothing. I'm standing there. Solitary, I'm playing alone by myself with my toys. Parallel play, toddlers. Toddlers don't share. They're next to each other, parallel to each other, playing with their own toys, not sharing. Mine, no sharing. And then it becomes associative play. This is preschoolers. Now they're sharing all the toys, they're all playing all together. They will share. Cooperative play is not only sharing everything, but there's a goal. For instance, checkers, somebody wins, or you're building a sandcastle and you built the sandcastle, or you built the house, or you built the racetrack. Whatever it is, there's a goal and you got that done by the end of it, okay? Janet, could you come on camera, please? So, role play toys. Toys are all about supporting your childhood's development. Again, it's picking the proper age toys for these children. It's making them noise or pushing them, pulling them, making that child use their muscle skeletal to get to them and move him around. It's all about developing themselves. So developmental assessments, I said, are important. We want to know what's going on with the child. We want to know if we have to put in growth and development, eh, early intervention, speech, physical therapy, occupational therapy. All these things do different things to help. Now, that child on the bottom left is a child with cerebral palsy. Okay? I can sort of tell by the way she holds her hands, the way her neck is, and you're going to say, well, how can I understand what's going on with her? Let's say she's nonverbal. Well, children will let you know. Even nonverbal, we can tell. We've got pain scales for them that we can take care of. And just because they have, something that holds them back a little bit, there's still the standards where they should be at. And our goal as a nurse, as we get them and look at them, is if we see delays, report it so that we can catch them up. I mean, a child who can't hold her head up by 7 months old, there's a problem. That should be done by 3 months at the latest, hold their head up. So, again, developmental assessments are important. Genetics makes a difference. There's all different deformitives that can happen at birth. There's all sorts of disorders. You've heard of things like Down syndrome, but have you heard of Prader-Willi and Turner? And I could go on with different syndromes that are out there. The thing that we know about some of these syndromes, some are genetic, some are because of the environment. And again, it's identifying what a child has and developing a plan of care that fits the needs of the child. Not all children are the same. They're all different. Okay, physical assessment, communication. First of all, remember there is HIPAA. Now, at 18, an alert-oriented, normal 18-year-old is going to sign their own consent and is responsible for their own care. Mom and dad need this child's permission to get any information. That is a HIPAA question. It's always on the NCLEX. So be aware at 18, alert oriented, they have to sign, and you need permission from that child to give the parents any information or to stay in the room even while questioning them. Now, talking to families, now this could be tricky. Now, the last 10 years I did emergency room, which I could have 30 kids a day, easy, right? So I have to get to the child, get to the parents, find out what's going on, address the needs, assess, and give the treatment and get them home, right? So I had to learn, how do you communicate with children the best way, the most efficient? I didn't have time to waste with just a bunch of people talking all at once. So I live in a community where there's a lot of Hispanics. Hispanics, everybody likes to tell me what's going on. Mom, dad, grandma, grandpa, aunt, uncle, best friend. So what we have to do, and all different cultures are like that. I mean, my children are half Cuban, Hispanic, so I understand it completely. But what I'm saying is, when you're talking to a group, number one, who's going to do the talking? You don't want 10 people telling you one thing at the same time, right? Oh my goodness, no. So, number one, have the parent tell me which one. Is it mom or dad? Cultural, sometimes. Sometimes some cultures it has to be the father, and some it's just the mother, right? Have them talk and listen. Find out what happened to the child now. Many times, a parent's going to tell you about a 6 or 7 year old child. They want to tell you from birth. Now, unless they are special needs or that some problem from birth that's still around, I just want to know what's happening this time. I have a cough and a cold. It started this day. I've done this and this, la, 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 right? So, directing the focus. And that's what that means. Again, that cultural awareness. Do you look them in the eyes? Do you don't look them in the eyes? Do you touch them? Do you not touch them? This is cultural. Many cultures don't want to be touched or looked at. Be aware of it, all right? Again, and if you don't know, always ask. One of the things you need to do is just listen. That parent has a sick child, especially the younger ones. They're tired. Most of them work, have other children. They haven't slept in a week, and now your child's in the ER, and they just want to tell you everything that's gone on because they're just out of their mind, right? Then that's when I come in. Wow, you have been through a lot. Wow, you've done a great job. I said, "You're such a good mother. Okay, let's see what we can do to help you now." What you've done is you validated them for all the great work they've done to get their child here and what they've done to get them there. And that makes parent feel better. That the nurse is saying, "Yeah, I did a good job. I didn't do anything wrong," because you don't know what influences are out there telling them what to do and how to do it, right? Again, don't do anything that's going to block communication. And interpreting should never be through a family member. It should either be a staff member or that beautiful blue phone. Don't do it with a family member because they're going to put their own interpretation on what that family is trying to tell you. Okay. Communicating with children. Now, walk into a child, an infant, that's easy. They usually will easily come to you easier than, let's say, the toddler, that early childhood, right? So, how do we communicate? Well, number one, you go into a toddler's room and you stand above them, you are absolutely scaring the crap out of them. Don't do it. I go in and I sit in a chair below them, and then I start with things like, "Wow, you got a Spider-Man shirt on. I like Spider-Man. Do you got webs coming out of your wrist like that?" Well, what have I done to that toddler? I'm now a cool person, and now I'm non-threatening. I'm below them, or at least equal to them. Never stand above, always below. And remember to do it in their age understanding. All right. What do they understand? Don't try to say words that they don't. Get on their developmental level and explain what's going on, whether infant all the way up to adolescent. Okay. And again, it's that non threatening pose, sitting down equal or below them. As I said before, the history, just find out who it was, that's going to be talking to you. Find out why they're here now. And then you're going to do your assessment, right? From what they're telling you. What history you need to know? Well, just a quick birth history. Were they vaginal? Were they C-section? Did they have to stay in the hospital? Um, have they ever been in a hospital before? Surgeries, etc. What do they eat? What don't they eat? Allergies, very important. And then medications, Tylenol, Motrin, right? Those are the big ones, especially if they're in for fever. And then immunizations is actually very important. You can't put two children in the same room with the same diagnosis if one had immunizations and one didn't, because it could be something that um, the immunizations could have prevented, like pertussis. You have to make sure checking that immunization status is very important. And again, growth and development, where are they? Are they been growing normally? And habits. If a parent walks out of the room, you need to know that that is their special binky or blanket, or that's their special doll or blankie or whatever, so that you know how to take care of that child. Taking a history on older children can be a little tricky. Most adolescents, I know it was me, I would not say anything in front of my parents about anything sexual because my parents would kill me. But we can now ask parents to walk out of the room, and we can ask this adolescent, older child about their sexual history. They'll be more apt to talk to you. Again, you're going to break and open that conversation by first, when you first see them, say, "Oh, you got a Yankee shirt on. I like that." Or, "What, you decided on college yet?" Or, "How's school?" Or you see them coming from a sports thing. Mention it. Again, open up conversation before it's just directly into that medical stuff, right? And that does help. When this child then talks to you and tells you things, you don't have to tell the parents what they said, unless it's going to hurt them or others, okay? finding out how they have done in school, how they are in school, can really help you with how compliant they might be, certain things. And then looking at, of course, always habits you look at, but parent-child relationships. Our ER had separate rooms for each child. And I know that I put a child or they, whatever, put a child in a room, I'd go check on them. And the parent would be on us in a chair on their phone or watching TV, the kid's on top of the stretcher, taking all those little black ear things out of the otoscope thing and throwing them all over, or in drawers and alcohol pads, and the mother's just sitting there. So I don't know how they're going to have that child behave at home, giving medicines. So I've got to be aware of that. Part of the history is, of course, nutrition. And again, making sure that nutrition is by their culture. Some don't eat meat, chicken, pork, cows, whatever. They're all different. Just be aware. Again, ask. Now, evaluation of nutrition. Now, we have children that could be too little, they're malnourished, or overly, and again, finding out what they eat, getting like always when you talk about nutritional assessment, obesity, or not eating enough, it's always doing food diaries. That's always going to be an answer to a question. It's always going to be about food diaries here. And you can find out, oh, they're drinking apple juice. That's why, they're very overweight. They just need to be drinking their formula at 6 months old or whatever it is. When you do the physical assessment on an infant, you do what you can do when you can do it, especially on any child, really, the younger children. On an adult, you do head to toe. It's not happening in the pediatric assessment. So what we usually do is a focused assessment, and then we get the rest of the body as we go. For instance, if they come in with upper respiratory infection, I'm going to be listening to their lungs first, looking for retractions, nasal reflaring, grunting, all of those things. I'm going to be looking at that. And as I can, I will look at bowel sounds and looking at the pulses, looking at fontanelles, all this other stuff is what I do later. Preparing the child for any examination, putting that child on the mother's lap is a great one. Your smaller children. Children feel comfortable and safe on the mother's lap, right? And again, as you are doing this assessment on a child, tell them what you're doing before you're doing it. And again, making sure that child feels safe as you are. Okay. And I know, like toddlers, I play games. So tell me, do you know where your heart is? And I even might want to try to have them listen. Again, you're going to be able to get a better assessment with that child not being upset. If something's going to hurt, no matter how much pain medicine, numbing, or something you're going to do, please be honest. It's going to hurt a little bit, but we're going to do everything possible to make it as little as pain as possible, okay? And sometimes, would you like me to hold your hand? And sometimes, yes. And that's okay. Again, age appropriate things you do. So, which approach would be best to use to ensure a positive response from a toddler? That's that 1 to 3-year-old child. How do you go and approach them? Anybody?
See?
Well, toddlers are ages 1 to 3. If you stand above them and start talking, they're going to be afraid. So, number one, get down on their level and talk quietly. As in, don't be screaming and yelling. Just talk normally. Okay? That is the best way to start. And then address them by their name. Okay? All the others could be, but number one, get on their eye level, get down to their level. So remember all those growth things. Remember, children are all different. All the vital signs are different. One of the things that we do every visit on all children is we do a height and a weight. And that's measuring nutrition, isn't it? It's also measuring a lot of endocrine system stuff, growth things and what. So height and weight are so important that we measure and monitor. Are they gaining weight appropriately or not? And if not, what intervention are we going to do? Also, knowing what their normal temperatures, normal pulses, etc., are. One of the ways I do blood pressures on that toddler is on their leg. If I can just do it in one blood pressure, they seem not to be as disturbed as it on their arm, and you still get a really, really good blood pressure. Children, you can tell by
Miss
looking
Bogart,
at them. Yes,
I have a question.
sure.
Is taking a blood pressure a typical part of P's vitals or no?
Yes, yes,
So it's just is it
yes.
just for like a maternity that it's not part of newborn vitals?
Maternity newborn vitals, you do 4 extremity blood pressures if you suspect any cardiac condition. You do blood pressures on every age children. You do. I've worked newborn. I have worked with brand new children coming out. And no, you do a blood pressure. And you do 4 extremities because sometimes we find conditions like coarctation of the aorta, which there's no blood flow going to the feet. And there's no other sign but diminished pulses in the lower extremities. So yes, we do blood pressures on all children. And Sakina, we used to not do them routinely in the emergency room, but we found younger children with
Mhm.
hypertension, and we want to treat that hypertension earlier, always by diet first, always by diet before any meds. But we can recognize it earlier and we can save things like kidney damage, can't we? So, very good question. Thank you so much, Sakina. Now, physical assessments,
Thank you.
children you can look at. You can know if they're sick or not. You really can. Um, if a child's walking in and they're pale and leaning over and holding their tummy, usually that right lower quadrant, that's going to be an appendix. If you see them retracting, you can see in between the clavicles right here, this clavicle right here, you'll see it pushing in all the way to the backbone. That's severe respiratory distress in an infant. Nasal flaring and that grunting end of each breath. It's just looking. I can see it and look at it right there. So again, looking at those things and getting your whole picture. And remember, children, you can't do all the assessment at once. Let's get what we need first. And if we're seeing that respiratory distress, we can go right to the lungs. We're going to look at all the everythings. We're going to inspect, auscultate. We're going to palpate, of course, checking the genitalia. We're going to see if they have an anus. Do you know, one of the things that maternity taught you is that you take a temperature at birth rectally, right? And they tell you to do it to see if their temperature is correct. Well, you're also doing it to make sure they have an anus. There are infants born that doesn't have it. And because there's mucus going down there, you have to have a correction pretty quickly. So it's an important thing to look for. The One of the things we also look at is their back, and we're looking at puckers and whatnot, making sure there's all these different things, little skin tabs on the ears, and these all can mean things. So doing that whole physical thing and looking at them. As they get older, we can do that neurological and doing all of those, reflex things. But younger kids, it's just an overall looking at the thing. Now, where do we do these sort of measurements? Now, infants, newborn ICU, newborn nursery, you're going to do a head circumference every time you come on shift for a nurse, for that baby. Do a head circumference. We're going to be making sure it doesn't get too big. And we're going to make sure there's no like hydrocephalus. Chest circumference at birth is bigger than a head, right? You were taught that in maternity. By about a year and a half, the chest should be equal to the head, or the head should be bigger than the chest by then. Okay, so there's that time where it turns around. And then in infants, before we feed them, we're going to be doing abdominal circumferences, making sure that they are digesting their food. Okay. And that's where we do these things. Another thing we do is height and weight. Now, on a height, um, you think that getting that little girl underneath that wooden board on top of their head is an easy thing. On some kids, it's not. So I make it a game. I go under it, I put my head down, I look at a number, I say, I'm a number 7. What are you going to be? And I'll pat it like that and hold it. I said, here, you hold it now, pat it down, let it touch your head. Ooh, what number are you? Now I've gotten a height, no damage, the kid's not stressed, and I've got the height that I need, for the nursing care. Blood pressure cuffs. They are from size 00 to extra large blood pressure cuffs, and you've got to pick the right one in order to take an accurate blood pressure. And you can see it's 40% of the arm for doing the upper arm. I'm telling you, I don't do the upper arm much on the younger kids. It's more the older children because they tolerate it better. I do D all the time. You can do it up, low, you can see where all it's done, but D, I think, is my favorite. And then pain assessment. I think it's probably one of the things that we have absolutely not addressed as well as we should. I think more children suffer in pain for longer amounts of time than they really should because nurses tend to be afraid to give drugs to these infants, but there's times where they really need it. So, children, they're not going to tell you they have pain. They don't want the medicine or they don't want a shot. Or you're trying to be that brave boy for daddy because the daddy says to be brave and you're not in pain, you're going to be all right. So there's many reasons why children continue to suffer in pain. The other thing is, as a nurse, are you doing your pain assessments? I mean, it should be done with every vital. It is your fifth vital signs, okay? Also, are you given the proper amount of medicines? You know, for instance, morphine is a great pain drug for children. It's been around forever. We've used it. We know the doses. Sometimes nurses are afraid to give a full dose. And if you're not giving a full dose, you're not taking care of the pain. Okay? Another thing, you haven't gone back and asked, did that medicine hurt? And did it help you? Did it help that boo-boo? Are you feeling better? And if they're not, they probably need maybe something to supplement it with, ibuprofen, acetaminophen. It could be something like that, okay? And then waiting too long between medicines. Again, children need pain medicines just like adults. They have surgeries, they have to get up, get out of bed, cough, deep breathe, do all those things, and it hurts. So make sure that they are medicated. Now, are you going to assess an infant? Well, they're not going to tell you I'm a 10 out of a 0 to 10 scale, right? We all know the adult scale. 0 is no pain, 10 is the worst pain in the world. Now, children have something called flat. You look at the child, it's an observation. What does a child look like? Is their face crumpled up and their chin quivering? That's telling you something. Are their legs moving like up and down, like you can tell their tummy hurts them? Or are they laying there not moving because they hurt too much? Are they crying? And if you try to pick them up, console them, hug them, whatever, do they console? Faces, legs, activity, crying, consolability is called flat. This is for your young child who can't give me a number. So any child under the age of 3 and all nonverbal children. Remember that CP girl earlier, nonverbal I told you about? She would have flat scale using to evaluate her pain. And it works really, really, really well. Now, the other one that we use for kids that are older than 3, 3 and older, okay? Remember that. Up to 3, it's flat. At age 3, it becomes faces. Faces are where they look at this scale and they point to the picture of how they hurt. And they do it really well. You'd be surprised. This is the other scale we use called a Wong's Baker Faces. And then the other one we know is the adult. It's a numeric rating scale. Put some other ones in there, but Flack, Faces, numeric is the ones you have to know. So, pain rating scale, make sure you use what's appropriate. Faces, it's 3 and up. Okay. At age 8, they say it's numeric. And then flack, as I said, it's nonverbal. And it's also those children who can't tell you, like the infant. Now, there's all sorts of pain that we can have. We can have chronic pain, recurrent pain, persistent pain, sickle cell pain. We could have a fractured arm, something, or we can have pain that we just can't get control of. Now, a kid who's in pain, and this could be your sickle cell, your rheumatoid arthritis, something, that inflammation. It When you have those sort of things, you're always in pain. And when they say chronic reoccurrent, that's longer than 3 months. Um, and it'll affect every part of this child's life. Physical, emotional, social, and in their school. They'll be missing school. They're not going to do as well. They're not going to be one around kids. They don't want to run. They hurt. They don't want to be involved. So again, addressing this is important and trying to get them control. Sometimes we don't know how to communicate. Again, it's cultural, sometimes cognitive delays. They won't use that Flack scale. There are some facilities that have other checklists. So, again, if you ever work with children or ever need to use a Flack scale, just go ahead and see for that nonverbal or cognitively impaired person or child. Do they have a special pain scale for them? And most facilities, they absolutely have to have one. And remember that cultural difference, like that little boy who didn't want to say he had pain, where he fractured his arm. He doesn't have pain because daddy said, no, suck it up, kid. You don't hurt. You don't have any pain there. You can do this. Let's just get your cast on and go home. Well, no, it hurts. Let him have something. Acetaminophen, ibuprofen at minimum. I mean, many times we try to give a little bit of morphine because we're setting an arm, a leg, or something, and parents are like, no, they don't need that. That's just a big drug. And we have to sit and take time and explain that it's a one-shot dose, that it will hurt, and we don't want their child to hurt. And of course, again, it's understanding those cultural differences when that child says, no, I don't have pain, and saying, are you sure? Really making sure, again, our child is our biggest concern and keeping them comfortable, okay? Some of the other things that we can do to help is distraction. Distraction, it's part of my dissertation that I love working on. Distraction could be music, could be things like coloring, could be painting, could be playing cards, using stickers, playing a game, watching TV. Distraction, distraction. Kids, give them an iPad, right? They'll go crazy and let me play a game. That can take that focus of pain away from their mind up front, and they'll be able to tolerate it better, okay? There's all sorts of other things. Infants, putting them and swaddling them really tight gives them comfort, and that can help. And then, that mother there on the bottom left has an infant on her skin, and that's called kangaroo care. I have had infants that are in an isolator or a warmer, and they're just really, they can't get comfortable. Mommy comes in, we put them on her skin and cover the child. You can watch the heart rate and the blood pressure come down, and you can watch the infants go sound to sleep where they hadn't been all day long. They were waiting for that comfort of mommy. So kangaroo care is amazing. Remember, with pain management, it's just not a drug. It's that distraction, right? It's using other things like acetaminophen or those ibuprofens. It is, of course, using opioids if we needs it, or what other type do we need? Children can have a PCA pump or a patient-controlled analgesia. It's that little thing you pump when you have pain. an older child that understands it can pump it. And remember, those things, they can't overdose themselves because there's lockouts. There's only a certain amount they can punch in a certain time period in between. So it is a great observation to use for some kids who've had like big surgeries. I want to say something like a Harrington rod. The whole spine had rods put in and it's painful. That could be one of those PCA pumps. And those are your adolescents, your young adolescents. So pharmacological management, we can do things like numbing an area. That girl there is smiling. She's got that little white blob and that thing on her arm. That is a numbing cream. And they put it there because she wants to come back and they need to take blood from her. And now, when they put a needle into the skin, you don't feel pain. You feel touch and no pain. And that's a lot of things we are doing in the pediatric population to decrease pain. We can do it for IVs, we can do it for spinal taps, we can do it for blood draws, many, many, many different things. Again, use it to keep these kids comfortable and happy so that they can get better quicker because they know what's going on and they're not afraid, and they won't be afraid to talk to you about what's really going on, because sometimes they won't. They're afraid to talk because you might do something to them and hurt them. And that's what children are, and you got to be careful with that. Untreated pain, again, there's nothing good comes from it. Children can have pain for many reasons. Teething is a big one in young kids. What about that circumcision on the boy as it goes on? The one thing that I had personal affair with is my grandson was living with me when he was first born. And he had a very tight foreskin called a thymosis. And we couldn't pull it down to clean it every day. On a male, you're supposed to keep it clean. Well, we went to the doctor and he said, no, it needs to be circumcised. Do you know how the circumcision was done in the office of the obstetrician's office? They take and they strap them in this thing, and they usually cry because they don't want to be strapped. They give them a pacifier with sugar water on it, and it acts like morphine. There is a article out by Harvard neurophysiologists or psychotherapists, from Harvard, and they looked at morphine and pacifiers with sugar water, seeing if there was any difference in pain control. There was none. So it's better to use that sugar water and a pacifier. Children upset, in pain, infants, give a pacifier. They'll soothe themselves. That's the point that I'm making here, okay? Another thing, common pain sites, we know if they've had surgery, etc. Yes, we're going to give them some for pain. So, which of the following is an important factor for consideration in understanding the pain experience in children? What do you think? Adriana, could you come back on camera, please?
P. E.
They will not admit to having pain. Absolutely. And it's common. It happens. Okay. Thank you. So we do have a Cahoots. We're going to go there. I have attached it to your PowerPoint. So you do have it. I'm also going to attach that to your recording that I sent out. All right. We're going to go to the Cahoots. Let's take 2 minutes, run for a little bathroom break, get something to drink, and come right back. Okay.
Wait, so I guess we're not getting a break. So we're trying to get my or we
Here's your Kahoots. You can start setting up for it. You can either take your cameras, put it on that little code there, or go to kahoot.it. That's your PIN number. Oh, is everybody ready? Now, just to let you know, I don't go back. I don't look at who got them right, who got them wrong. This is something that I have here for you to test your knowledge on things that we've gone over. Also, this Cahoots also brings up information for next week's information on infants, toddlers, and preschoolers. So it starts to brings you into it all, okay? All right, let's get going. Week 1. The leading cause of death from unintentional injuries in children is, I did mention. So it is motor vehicle accidents. That's number 1. Remember I said as infants, it's the car seat. How the car seat is inserted if they've done it correctly. And then again, as they get older, it's now that they are driving and now creating accidents, et cetera, et cetera. That's always accidents, injuries, motor vehicle number 1. Which statement is most descriptive of pediatric family-centered care? Remember, pediatric care is just not a child, it's the family. And if we know that the only thing a child really understands as a young child is their own family. So the family is the constant in their life. This is what they know, and this is the way they act. This is all their customs and cultures and what they eat, et cetera, et cetera, et cetera. The major cause of death for children older than 1 year is, hmm, so older than 1 year, these are toddlers. They're getting on top of couches and they're jumping over to the other couch and they're climbing up things and falling. This is what kids do, right? Especially those toddlers. And you've got to let them try a little bit, but not to the point where they're going to fall on their heads and hurt themselves. It is unintentional injuries. Yes. The nursing care for the child in pain understands that distraction. So distraction has to be developmentally appropriate. I mean, you wouldn't give playing cards to an infant. That's what I mean. Okay. Or if you're with an infant, maybe it's a little rattle, but you wouldn't do that to a 4-year-old. So again, developmentally appropriate. Good. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? Where I talked about parallel, I talked about associative, I talked about cooperative. What's the difference? Solitary is alone, so it's not that. It is associative. Parallel, think about a parallel next to each other, not touching. These are toddlers. Toddlers don't share. Me, mine, and they grab things out of other kids' hands. That's parallel play. Associative, now they associate with each other and they play all together. but there's no goal. Cooperative, now they're going to do something. They're going to build a track, build a house. They're going to play checkers. They're going to win the game. There is a goal. There's a finish to it. Okay. Which statement best describes the process of critical thinking? Isn't that the thing they told you in orientation? You're going to be taught how to critical think. So have you figured out what's for dinner yet? Do you have it at home? Do you have to go buy it? Do you need some pieces of it to make it? Because your goal is dinner, right? That's critical thinking. It's as simple as that. We make it into this big thing, but all it is we know what we want and we know what goal, right? So how do we get there? That's critical thinking. And that happens in children. A child is not breathing well. What do I have to do? Well, I want them breathing better. So this is what I have to do to get there. Critical thinking. What steps do I have to do to get the goal I want? Simple as that. What is probably the single most important influence on growth at all stages of development? Nutrition, 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 nutrition. If you don't put gas in the tank, you're not going to grow. You're not going to think. That's as simple as it is. Very good. Which function of play is a major component of play at all ages? What does it do? It's all about the touch. It's all about the movement. And of course, the world is explored in the mouth. Everything goes in the mouth. I mean, I have an 8-year-old grandson who still takes a shirt in the mouth, pencil in the mouth, a this in the mouth, a popsicle stick, and he doesn't take it out. Oral, big, big thing in young children. The touch, the mouth, the motor, moving it around, and that's how they explore. You apply nystatin to an infant with thrush. What do you think? Nystatin, remember, thrush is that white stuff on the tongue. And you can't scrape it off. It's yeast. So we put something called nystatin on it. How are you going to do that? Well, you're not going to squirt it into the side of the mouth because that's not getting it onto where the thrush is. It's usually the tongue. They're not going to swish and swallow. So you take a cotton swab and just paint it on there. That's it. Okay? As simple as that. It's a question you're going to see. Trust me. 3 children playing a board game would be an example of what type of play? They're playing checkers. I win. And that is cooperative play. When there's a goal, there's something that somebody wins the game or a goal has been met, that's cooperative play. Associative play is they just associate together and they all play and they play and there's no goal. The head to tail direction of growth is referred to. Think about words that mean head and think of words that mean tail. It's simple as that. Sometimes it's just as simple as that. I think we tend to overthink. And then I'll say why. Cephalocaudal, cephalic, head, caudal, feet. I lift my head, feet, then I walk by the age of by about 1 year old. So that is telling you I start with my head moving and then the rest of it works to the point where then I'm standing and walking. What is the single most important factor to consider when communicating with children? Get on that child's developmental level. I mean, that's number one. I mean, children, yes, do better with parents at the bedside. I understand that. But that child's not going to talk to you, even with the parents there, if you're not, number one, get down on their level and then talk to them in a manner they understand. They're just not going to do what you want them to do or say or, explain anything. So again, child's developmental level, big, big, big concept there. What 2-year-old pain assessment tool should the nurse use? So remember, we have FLAC, we have FACES, we have numeric, which is another one, it's another pointing to it, but the other three we use. So it's not Oucher. So at age 2, it's FLAC. At age 3, it becomes FACES. This is a question you are going to see. You need to know. FACES starts at 3. It's FLAC before then. Also, nonverbal are FLAC. At 6 months, an infant's birth weight should what? Well, I told you that 7-pound baby at 1 year old has tripled his birth weight, right? At 6 months, what do you think they've done? And then I'll say, why do we need to know? It's actually, we double at 6 months. Now, why do we need to know these things? Well, if a baby was born at 7 pounds and at 6 months he's only 9 pounds, he's not gained enough weight. Whoops. Nutrition, not cognition's going to be down, probably growth development's not going to be at where it needs to be. This is a child with failure to thrive. This is a child who's underweight and needs extra calories or something to catch them back up. So knowing at 6 months it should double can give you the clue. Doesn't have to be exactly, a little more, a little less, yeah, but it should be about 6 months. At 6 months, it should be doubled, and at 1 year, it should be tripled. The first expected fine motor development with infants begins with what? And as I said, it starts out with the grasp, right? First thing they can do is usually mommy sticks their finger in them when they're brought to them, and the little baby just all of a sudden grasps their hand. And it's actually a reflex. They don't do it by themselves at first. It's a complete reflex. And then about a month or two later, all of a sudden now they can grasp by themselves. So a reflex palmar grasp is number one, is by the palm. And they just put something there and by reflex, they grasp around it. As they get older, they're grasped by themselves, called a voluntary palmar grasp. Then it goes to pincer grasp, which is picking up little Cheerios, right? But it first starts with like a crude smush in the face Cheerios. And then it becomes one at a time, nice like that. And then they put things into containers. And by 1 year, they make a block of 2. It's using hands to do things, okay? An 8-month-old infant should be expected to perform which fine motor skill? So, fine motor is F about fingers. Okay? Fine motor, fingers. What should they do by this age? What do you think by what I just said about that reflex and that voluntary grasp? They should grasp it and use a crude pincer grasp. Yes. Now, that absolute pincer and putting things in is about 11 months, and then the blocks of 2 is by 12 months, according to the book. The natural physical developmental sequence that most children follow is, what do they do? It's their movement. How do they start moving? Where do they start moving? Again, we're going to go over it more next week, but this is introducing. This is things that we should know. And then when do they do those things? And if they're not, what early intervention did we did? And this lifting the head is first, is what I've told you. And then they roll over from front to back, back to front. Then they're up on their knees and crawling. Then they're standing up on the couch and they're crawling around, cruising. And by 12 months, attempting to walk or they're walking. It doesn't mean a kid can't walk by 7 or 8 months. Sure can. My kids didn't walk till 18 months, 15 months, and they're still smart kids. It's just, remember, all children are different. As long as they're cruising, attempting to that point, we're good. Not all children come along on the same time. Nope, they're all different, they're all unique, and that's why I love pediatrics. They're not like adults. Children are different. You really got to use great assessment skills to take care of them. Which behavior indicates that an infant has developed object permanence? Well, object permanence. This is when you show them that teddy bear and then you hide it. They know it's still there, even though they can't see it. And they go looking for it. Like you take their toys and you put them in their toy shed, their toy box at night, right? They know in the morning they're going to go look. They know that toy is going to be there. That is object permanence. And that starts as a young infant. Okay. They know they've seen the rattle. They know it's there. They go looking for it and they start wiggling, and it helps with their body movement and muscle development. In general, an infant should triple their birth weight at what months of age? And that's at 12 months. At 6 months, they double. Perform a head to toe assessment on a toddler. Most important to consider before beginning the examination. Toddler, ages 1 to 3. You got to do an assessment. What are you going to do? So, number one, you're going to get down on their level, and then you are going to base it on their developmental age. You don't want to use words or do things that they're afraid of, and you're going to explain things very simplistic to them. And once they learn, you'd be surprised, even young toddlers, you tell them what's going on, they're going to be more willing to do what you want them to instead of fighting, screaming, and running down the hall. And they will. Watch them. Catch the kid. According to Piaget, toddlers are in the blank developmental stage. Remember, this is all about cognition and thinking. Piaget is all about they learn to suck. They learn to put their finger in their mouth. They learn to shake a rattle. It's sensory or motor. It's touch, mouth, and the movement of it. That's what toddlers do. They're feeling stuff and knowing what things feel like and putting it in their mouth because they explore the world in their mouth. And then they're moving it, flying planes and cars and whoever, Superman, and they're flying around. Sensory or motor are the toddlers. Which intervention helps a hospitalized toddler feel a sense of control? Now, having a toddler in a hospital is pretty hard. You know, toddlers don't like change of environments. So, number one is that if we can follow the routines that that child has had at home, the child will be better. I mean, if a parent can stay at the bedside at all times, oh my God, that's exactly what they need. But many parents have to work. They have other children, other commitments. They can't, and they have to sometimes leave and come back, right? So as a nurse. If we follow their routines for feeding, bedtime, when do they take their bath? What do they eat? Are we feeding the food that they want if they can in their diet, right? If we keep it that routineness, the child's not going to be as, upset and worried, right? Again, follow the routine, getting on their level. And of course, parents can say that's always number one. All children reach developmental milestones at the same age. Yes or no? Absolutely not. And that's why, again, children are so great to care for, because you've got to figure out, where are they? So immunizations for a 4-month-old infant, which action should the nurse take to provide atraumatic care for that infant? How are you going to decrease the pain level of that child? It's basically what that's saying, isn't it? And again, it's that pacifier with a little bit of sugar water on it. It acts like morphine, and it works really, really, really well. In fact, working in the emergency room, and we used to always do blood draws and IV starts and sticking things in noses and ears and throats, whatever. We would absolutely give them, the young children, a pacifier before starting that IV or anything, and it would comfort them, because we don't want them to be afraid. You'd be surprised. Infants do have a little bit of memory that they keep. So when they come back again, they have a feeling something's not right here. Okay. Which of the following immunizations is administered to a newborn? And my daughter is due a baby in 2 weeks. And she's right now, do I do this or not? And I'm like, I'm a pediatric nurse, pediatric professor. I do believe in immunizations, but you got to let your kids do what they want. But the first one we give, usually in the hospital, is hepatitis B. Then, if it can't be done in the hospital, you'll see things like the insurance didn't cover it. They have to give it at the first visit in the doctor's office, all those sort of things. But it is the first immunization, whether in the hospital or at their first visit to the pediatrician. The normal heart rate for an infant is, now, the reason why we know stuff like that is, what if you were given digoxin to this infant and their heart rate was 100? Would you give it? You see, is it a good heart rate? Is it not? That's why that we need to know these things. So an infant is 140 to 160 at rest. When they're upset and crying, it could be 200. What is the preferred site to give an injection to an infant? Do you remember pharmacology? And that picture is
Thigh.
absolutely the wrong way to give it. Yes, it is. But that picture, what's wrong with it? Somebody should be holding that child's hands.
We see a photo of a heart, or at least I do, unless mine is messed up.
So it's called a vastus lateralis, and that's in the upper outer thigh, and that's where we give infants to them. We don't go into the buttocks area until they're walking, is what they say. The death of an infant under 1 year old with no known cause. As you can see, I'm giving you a little bit of next week and this week and introducing these things to you. And it's called SIDS. We're going to go into that more a little bit next week, and what are the risk factors for that. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why? Why do you think? And it's actually what we call respect. And if we didn't understand that we need to look for cultural differences, we may not see that, right? So that she's showing you respect, telling you, that she's respecting you and won't look at you. And it's just part of who she is, and that's part of her culture. A child from Mexico is hospitalized for a serious illness. The father says the child's being punished by God. Why is he saying that? And again, it's another health belief. I'm just showing you some things that you may see, and there's so many more. I could go on and on with this. Which term refers to individuals in a times in an individual's life when he or she is more susceptible to positive or negative influences? Again, this is just a definition out of your book. Always, go through and read those definitions at the beginning of your chapters, and look at them. It's basically just called a sensitive period. It's the time where they're susceptible, they're sensitive to it. It's easy as that. What is characteristic of the pre-operational stage of cognitive development? Now, this is Piaget. This is giving you a word and something to think about. This is after toddlers. This is more into your preschooler ages. What do you think a preschooler thinks about? Thinking is concrete. What does that mean? I mean, all of these words, right? It means concrete. You can see it, touch it, feel it, smell it. I've seen it before, so I understand it. They don't know something they've never seen before. But if they've seen something, they can understand it. Okay? That's what that means. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? What did I tell you about Kohlberg? What is he all about? So Kohlberg is all about morality, right and wrong, good and bad. And preschoolers actually are reward and punishment, which is good and bad are the consequences. So good has consequences and bad has consequences. So it's reward and punishment. Let's see how we did today. So we have Ashton, we have Shay, and number one is Jerry. Good job, Jerry. Number four, Kanea and Clark. So, did you enjoy the Cahoots? Do you think they are a good thing right after a lecture to help you with some understanding? Also, introducing your, next week with some stuff there. I think some big concepts were hit there. I will be upposting your recording when I'm done here. I'll also, again, reattach the PowerPoint. I'll attach the other two attachments there, the Erickson. Again, I find if I attach it in more than one place, students find it. If I put it only in one place, it's not. Always, if you're looking for something, always go to the announcements. Again, if for some reason you can't open it, let me know. Okay, there's somebody on here that has just an iPad on your name. Can you put your name there or your attendance will not count? And if you can't, I'll do it for you. Tell me your
I
name.
think it's me.
Yes, it is. What's your name?
Ivory Rhodes. I had switched from my phone to my
Ivy,
iPad. Yeah.
Ivy, Rhodes.
Ivory, Ivery, and then
Yes.
Rhodes, Rhodes.
Yeah, I don't want anybody to not get attendance because I
Thank
wasn't
you.
checking those things out. No, not a
Thank you.
problem. You're close enough there. All right. Any questions about me? What I expect from you? What you need to do for this week? And know that next week we'll be having our first quiz. 10 questions. You're going to see stuff that comes from PowerPoint or the Kahoots will be on your quiz. Okay? All right. If that's all we have, you guys didn't have a break and you get 10 minutes per hour. So you get about 25 minutes. You've got your 25 minutes and have a good day.
Thank
Have a
you.
great day, guys. No, you're more than welcome.
Thank you.